Hello, everyone, and welcome to this edition of Let's Talk, presented by the Visiting Nurse and Hospice for Vermont and New Hampshire. My name is Anthony Knox, and I am the Community Relations Manager for the VNH. Today's program we're going to be talking about is our hospice program for all of the end-of-life care that an individual may need. This is the leadership team that helps out with providing that support. So we're going to go around and each member of the leadership team is going to introduce themselves, and then we're going to dive right into to the program. So Jess Cheney, lead it off.
Thank you, Anthony. My name is Jess Cheney. I'm the Director of Hospice at the VNH. I've been here for almost 2 years next month. I transitioned to this role after spending the first part of my career at Dartmouth-Hitchcock. I've always been interested in hospice care, so this role came along at the right time. So here I am.
All right, I'll go next. I'm Jess Allen. I'm the Hospice Nurse Clinical Manager. I have been in this position since June of this year, and I have been with VNH for about 15 years now. Most of it has been in direct patient care as a nurse case manager, also serving in care coordination and triage roles, most recently prior to this.
Hi, I'm Jennifer Lander. I'm the clinical nurse leader for the hospice program, and I've been in this role almost 1.5 years now. And prior to starting this role, I did about 10 years of inpatient care at Dartmouth.
And I'm Christine Maloney. I'm the Hospice Medical Director at VNH. I've been at VNH about 6 years full-time and 2 years part-time before that. And prior to this role, I was doing a combination of primary care, internal medicine, palliative care consults, both inpatient and outpatient at Gifford Health Center.
Excellent. Well, thank you all for being a part of this presentation, and we're going to dive right into to the PowerPoint presentation. So again, this is Hospice 101, and Dr. Maloney is going to start us off.
So I wanted to first talk about some terminology. So what is palliative care first? So this type of medicine focuses on patients with serious illness, with a focus on managing symptoms that a patient may have because of their illness. So examples might include pain, nausea, constipation, shortness of breath. And the emphasis is on enhancing quality of life and helping with decision-making as patients have changes in their illness over time. Hospice applies palliative care to patients who have a life expectancy of 6 months or less. Hospice is a Medicare benefit, and so to qualify to use Medicare for hospice, 2 physicians need to believe that your prognosis is 6 months or less should the disease run its natural course. Patients who are agreeing to hospice understand that the goals of care are palliative, meaning focused on symptom management and quality of life rather than on curative treatment. And so hospice deploys nurses, doctors, chaplains, social workers, and volunteers, that's my own addition, to help people with fatal illness have the fullest possible life right now.
Perfect. Yeah. And we will, towards the end of this presentation, we will talk more about volunteering as a part of the hospice program here at VNH.
So for folks who do better with an image of this versus words, this is another way to look at it. So all of this is palliative care. Hospice care is a subset of that, again, primarily focused on patients with a prognosis of 6 months or less who are focused on quality of life and symptom management.
So for somebody who has a life expectancy of longer than 6 months, so that's where the palliative care piece comes in to provide that support prior to when they quote unquote qualify for hospice care. Is that correct?
That's correct. So palliative care is best done alongside more traditional treatment. So palliative care could start at the time of diagnosis with a serious illness like cancer, congestive heart failure, COPD, or chronic obstructive pulmonary disease, or even Alzheimer's dementia, to focus alongside traditional treatments on quality of life and decision-making as the illness changes over time.
Okay, gotcha. Perfect.
So some numbers around hospice use in the US. 52% of all deaths in the United States are patients on hospice. In Vermont and New Hampshire, these numbers are actually a little bit lower, although have been increasing over the past several years. The median length of time on hospice is 24 days, and the average length is 76 days. And unfortunately, many folks are on hospice a very short period of time. So about 40% of hospice patients are only on hospice for 14 days or less, even though the benefit allows someone to be on for about 6 months. In 2018, about 30% of hospice patients had cancer as their primary medical condition, 17% with a cardiac condition, 16% with a form of dementia, and 11% with a respiratory medical condition.
And Dr. Maloney, has there been any studies or anything as far as why patients don't necessarily elect to be on hospice sooner rather than later? More of a emergent need, I guess. At 14 days versus being able to be on it for up to 6 months or 6 months prior to the terminal date.
I think there's a number of theories about why this is. I think one of which is that prognostication can be challenging. And so folks are sometimes concerned about being that one doctor who says a prognosis is 6 months or less. If they're thinking, ooh, I'm not really sure, they're likely to wait longer before having a conversation with someone about hospice care. So I think the challenges of prognostication is one reason. Another is that I think particularly cancer patients are often doing a lot of treatment. They're doing anti-cancer therapy, and that continues because there's lots of choices in cancer therapy. So that continues for a long period of time. Finally, I think there's still some fear in our culture about talking about death. And so people often just don't want to bring it up. Sometimes patients are afraid to talk about it. Sometimes providers are afraid to talk about it. Sometimes family doesn't want to mention it, even though people see things are changing over time. Someone needs to be the one who brings it into the subject of discussion, and sometimes that can be challenging, and people are uncomfortable with talking about this. And so those are at least some of the theories for why people wait so long.
Okay. And so based on the numbers, the percentages of the different terminal diagnosis, is that the same that we see at the VNH as far as, most of the patients that we were treating on hospice are cancer related, and so on and so forth?
So I just took a look a little earlier today to see what our current mix is. And at this moment, we're a little bit higher with cancer patients than these numbers, which again are from 2018. We're also a little bit higher with cardiac patients than this number. Our dementia and respiratory number very similar to this. But this does, again, sort of change over time. Sometimes just have a lot of dementia patients on or a small number of cancer patients. But these 4 diagnoses are certainly the 4 most common diagnoses we see at the VNH.
Okay.
It's also worth mentioning that these are not exclusive. So we have patients that are on hospice for other reasons besides these 4. These are just the most common.
Okay, perfect. All right.
So nationally, around 56% of hospice patients are living at home, and 43% are living in a nursing home facility. For the actual location of someone's death, 51% are dying at home. This number passed 50% for the first time just in the past couple of years. 70% are dying in a nursing home, 13% in a hospice inpatient facility, 12% in an assisted living facility, and 7% in another location, maybe the hospital.
Okay.
So because hospice is a Medicare benefit, sometimes patients and families have questions about what hospice will actually cover. And so this is a list here. So it covers all of the personnel that we mentioned in that earlier slide. So visits from nurses, home health aides or LNAs, licensed nursing assistants, medical equipment and supplies, medications that are related to the medical condition, which results in a 6-month or less prognosis. So as an example, to make this maybe a little simpler, a patient who is on hospice for congestive heart failure, their cardiac medications would be covered. Any medications for symptom control, so that would include medications that help with pain, anxiety or depression, nausea and vomiting, shortness of breath, or any other symptoms a patient has because of their illness. It covers visits from a hospice social worker and chaplain. It also extends after the patient dies. And so grief counseling is provided for patients and families for a minimum of 12 months after the patient dies. There are some other options to be taken care of in a different setting if they're appropriate. And so patients may be transferred short-term, inpatient to help with symptom management with the goal for them to return home after those symptoms are better controlled. And also short-term respite care. And this is focused on caregivers so that a patient can spend up to 5 nights in a different location to give caregivers a break during this period of time.
And is there anything that the Medicare hospice benefit doesn't cover? Because I mean, that's a pretty exhaustive list of stuff that it does cover.
So I think the most common things that it does not cover, sometimes people are on medications that are not related to the medical condition that they're on hospice for. So an example might be medications for glaucoma or macular degeneration. So eye drops, those would probably not be covered by hospice. Sometimes patients have very specific customized equipment that would not be covered by hospice services. And it doesn't cover the things that folks most traditionally think of as Medicare covering. So repeated trips to the emergency department, a lot of imaging like CAT scans, x-rays, MRIs, and lab work, again, that seems not related to the reason that they're on hospice services. Those, as we talked about in that earlier slide, any type of curative treatment, again, would not be covered under the hospice benefit because the philosophy is very different here, focused on quality of life and symptom management. So it does vary person to person, and it's certainly a question that folks could ask in advance of being admitted to hospice or at that first visit, just if they have specific questions and would like to clarify things that might not be covered.
Okay, perfect.
I wanted to certainly go over a number of hospice myths, in part because we see them all the time. And so I think it's helpful to talk about things that actually are not true. So patients must be DNR or do not resuscitate to be on hospice. This is not a requirement to become a hospice patient. It's certainly something that we would discuss with patients and families over time. But again, it's not a threshold requirement to start a hospice episode. Patients must give up their primary care provider to be on hospice. This is also not true. In fact, a primary care provider is another member of our team. So patients get to choose who they want to be their attending during their hospice stay, and many choose to have a continuing relationship with their primary care provider while they are on hospice services. Patients are forbidden to go to the hospital on hospice. As we just discussed, sometimes transferring short-term to the hospital for symptom management makes sense for an individual patient. We just want to make sure that that care is coordinated by the hospice team so that the goals of that short-term hospitalization are very clear, both to the hospital that's receiving the patient and to the patient and family. Hospice provides 24/7 care in the home. Unfortunately, hospice does not provide this. There are visits by all of those team members that we discussed earlier, but hospice does not have the availability to do shift work or 24/7 care. We do rely on family members, sometimes paid caregivers, friends, neighbors, to help with care in the home. Hospice hastens death. There's actually a slide a little bit later about, for many diagnoses, hospice actually lengthens or at least doesn't shorten someone's life expectancy because the goals of care are very different. Patients cannot be on hospice longer than 6 months. While 6 months is a guideline, it's not a deadline. And so there are often patients who we reevaluate who continue on hospice care longer than 6 months. Patients can only be on hospice once in their lifetime. So sometimes patients will be on hospice for a period of time. They will stabilize or even do better, and they'll come off hospice for a period of time. You could come back on later if things with your illness change again, or you decide that maybe you want more treatment or different types of treatment for your illness. You may do that for a period of time and again come back onto hospice later. Patients can't live alone or live in a nursing home. We commonly take care of patients in both of these situations. So patients who either live at home without a identifiable caregiver, or patients who live in a nursing home. Again, both of these are not prohibited on hospice services. And the last on the slide here is all patients on hospice die. So there is a small minority of patients who end up being discharged from hospice services because they are doing so well that we think they no longer have a prognosis of 6 months or less. These are sometimes the patients that come back to hospice later as their illness progresses or changes.
All right.
And so this, I guess, is the slide I was just alluding to. So there's been some nice studies around Medicare patients with different diagnoses. And so, again, because of this myth that patients who are on hospice have a shorter life expectancy, they actually followed patients and found that often it was the opposite. So for breast, prostate, or colon cancer, there was actually no difference in survival for these patients. But for patients with pancreatic cancer, they actually lived about 3 weeks longer. Patients with lung cancer, 6 weeks longer. And patients with congestive heart failure lived 3 months longer. These, of course, are averages, but they have been replicated in a number of different studies that hospice definitely does not shorten life expectancy, and often you live longer.
So was there a reason as to why those 3 cancers in particular, there was no difference in survival time, but pancreatic and lung cancer, there was a longer survival time?
So it's harder to see the difference between cancers, but one of the theories is that sometimes patients are getting anti-cancer therapy when they're in a pretty weakened condition or have advanced disease. And so by stopping that anti-cancer therapy, people get a chance to recover a little bit. And that just by stopping the therapy, folks actually do a little bit better. There's also a focus on symptom management that may be more intense, and a focus on quality of life. And so people who have spent a lot of time getting anti-cancer therapy, going back and forth to the hospital, are expending a lot of energy just in getting treatment. And so the thought is that by stopping that, folks get a little bit of a break and a focus on something else, which does extend their life.
All right, perfect.
So to end my piece here, hospice is both a philosophy of care, again, a way of being taken care of, and it is an insurance benefit through Medicare. Patients who are on hospice are being taken care of in the place where they live, be that at home or in a nursing home or another type of facility in assisted living as an example, with a focus on comfort and quality of life. And hospice is truly underutilized as a way to take care of seriously ill patients during the last chapter of their life, because folks often wait before making this transition.
Well, this is, I mean, just great information about, the hospice services themselves and the myths around it, and just having this information is great. Dr. Molloy, thank you for going through all of this and all of the specifics as it relates to, the hospice services and the care that's provided. And with that, we will now transition into the different roles of our hospice leadership team. I am going to call on Jess Cheney to start the conversation around these different roles.
Thank you, Anthony, and thank you, Christine. So the next part of this presentation will focus on our VNH hospice leadership team and how each of our roles help support the hospice direct care team. So as you can see in this diagram, you can see where hospice director, hospice manager, and clinical nurse leader work together. So a little bit about the hospice director, which I'll go into next, which is my role. Sort of that big picture development of the hospice program and the overall person who oversees daily operations. Our hospice manager, Jess Allen, we were lucky enough to have this new role start this year, which is really exciting for our team. But she focuses on the day-to-day operations and really just the direct direction with our direct care staff. She's there and doing that work. And then Jen Lander, of course, in the clinical nurse leader role, is her main focus is on quality improvement, long-term project development, and another support for our staff. So my role, a little bit more about my role. So again, I'm the person who works in the big picture thinking in regards to the development of our hospice program. So all the ideas that we think of and then we work on, I sort of bring to the executive leadership team and we work through those. All of the projects that we talk about are to help to continue to provide the excellent support that we do to our patients and their families. The last few months, I've really been diving into meeting with our referring providers. It's something that we haven't been able to focus on in a while due to the pandemic. So I have been taking the opportunity to go out to meet all of our referring providers in our very large coverage area. So as far as Randolph, all the way down to Brattleboro, having the opportunity to go and meet and just to understand what it means from their perspective for us providing hospice care to their patients. I focus on recruitment and retention, so bringing in all of our direct care staff, but from nurses to chaplains, social workers, and LNAs. Focus on billing, work on staff meetings. I work with Jess and Jen on education for our team. Again, have that big picture oversight of clinical operations. So work side by side with Jess and Dr. Maloney on this. And then, of course, continued support of growth and development for our hospice team.
Excellent. And now Jess Allen.
All right. Thank you. So I'm in the hospice manager role. I am part of the operational team, overseeing direct care staff and facilitating and coordinating staff and patient needs, collaborating as far as coordinating with referral sources, day-to-day scheduling pieces. I do case reviews and chart reviews with staff, as well as perform joint visits. Um, and then I work in conjunction with Jess and Jen both on continued education for our staff, just to ensure skill um, on our team to care for patients with a wide variety of needs. I've also joined up with Jen for multiple projects in the past few months. We've implemented a telehealth program, are working on a home care to hospice bridge program, and a volunteer program as well. My background prior to this role was as a nurse case manager in patient homes, and then in a care coordination and triage role for the past 2 years or so. Being in both those roles has given me, the experience and background to understand what our staff and patients are going through day to day. And in the triage and care coordination role, I was really able to see the bigger picture needs of our patients and staff, and have been able to bring a lot of that to this role.
Awesome.
All right, thank you. Jen?
All right, thank you, Jess. All right, so the role of the clinical nurse leader in hospice is a very exciting and innovative role. And in fact, the VNH is the first home health agency in the country to have a CNL in hospice. The role was developed about 20 years ago and resulted from the realization that nurses who have been specially trained in healthcare quality improvement can also improve patient outcomes. Clinical nurse leaders are master prepared nurses who are trained in and have a focus in the following. So care coordination, outcomes measurements, transitions of care. So these transitions of care would be from inpatient to outpatient, or even different units within the hospital. They also focus on interprofessional communication and team leadership, risk assessment, implementation of best practice based on evidence, and quality improvement. So as a CNL, I'm positioned as a non-formal leader in the hospice team. So essentially my role as a CNL allows me to work between both worlds of leadership and frontline staff. I'm very fortunate to work in conjunction with Jess Allen and Jess C. This role in particular allows me to build strong working relationships and have an understanding of the entire system without being involved in the performance evaluations or disciplinary actions that both of the Jesses need to get involved with. My goal is to provide a safe place for staff to feel comfortable sharing issues or concerns, and to engage them in being active participants in quality improvement projects. I use the professional relationships that I build and the understanding of the system to identify areas of improvement and to design improvement initiatives that meet the diverse needs of the staff and the patients we work with. Often these projects are longer-term projects that support the daily operations that both the Jesses focus more on. So some of the projects that I've been working on, Jess Allen had already talked about some of them with the bridge process and the volunteer program, but I've also done some projects to increase the protective equipment for staff, so making sure that they have specialized masks to prevent smoke inhalation in the home from cigarette smoke. I've also been a big part of the electronic medical record transition, so helping to support staff with education during that, as well as working towards optimizing the system to make it work as efficiently as it can for us. And then one of the big parts of my role is to focus on quality in the last days of a patient's life. We know that based on studies that symptom management increases on the last couple days of life, and the goal is to increase staffing visits during those days to meet those needs. So part of our process is to figure out how do we identify these patients who are on the last days of life so that we can then increase the visits and get the symptom management needs met. Another aspect of my role is to increase communication and coordination between the teams. So I work with the interdisciplinary team group. For each patient, we meet once every 14 days to talk about them and to plan the next 2 weeks and make sure that all the team is on the same page. And then lastly, working on those volunteer and bereavement programs with Jess and Jess.
Wow. Okay. That's a lot. So, and so, for all, well, I would say all four of you, I mean, obviously you all have your distinctive roles within the hospice team, but at the end of the day, you're all coming together to ensure that we just continuously provide the best hospice care to the patients that we're serving. So that's perfect. So, and so Jen, one of the things you mentioned there at the end was around volunteering for hospice. So here's some information about our volunteer program. Take it away.
Yes, thank you, Anthony. So we are very excited to start working. Since September, we've really started to work on rebuilding our hospice volunteer program. We had a few volunteers that stayed with us through COVID, and we really appreciate their commitment. And now we have time to commit towards building that program and bringing in new volunteers. These volunteers are very important to our patients and their families, and they're truly a part of providing quality of life to these patients and their families. So if anyone is interested or has someone or knows someone who might be interested, certainly reach out to us. We have a group email, which is vnh_hospice_volunteer@vnhcare.org. You can also call, this is actually Jess Cheney's number, so 802-478-4690. And then we also have an application on our VNH Care site, and you can find the application under the volunteers section. So oftentimes volunteers will think that they need to have a specific skill set in order to volunteer, and this is simply not true. Oftentimes just being able to be present with that patient and their family during this time is the most important. And so some of the things that our volunteers provide are companionship, respite, so that caregivers and families can take a break. They can read to patients. They can look at magazines, pictures, books, scrapbooks, play card games, Scrabble. They also can just sit and listen to stories or maybe record some of those stories or special memories of the patients and their families. And that's a really great gift to be able to pass on after they're gone. They can deliver or prepare meals. They can run errands. We also have some volunteers that can work in the office to do some clerical work. We have some volunteers that can do bereavement support and mailings. As we talked about earlier, we provide bereavement support for a minimum of 12 months. Volunteers can also do crafts with our patients, or they can do crafts and donate them. We also provide a veteran-to-veteran visit. So volunteers who are veterans, we can pair them up with patients who are veterans to provide that additional support. And of course, all of our volunteers come in with different skill sets or different ideas of how they want to volunteer, and we certainly are open to working with them to make sure that we match them with the right patients.
Awesome. Yeah. So, I mean, again, there's a million and one, possibilities of how you could volunteer to, support these individuals in their, in their last days and weeks and months, and every little bit helps. So again, if you go to vnhcare.org, all of the information about volunteer services is right there on the website. And so before we go, I just wanted to make sure that there was no other information that any of you wanted to share about hospice services or anything like that, that maybe just didn't get touched on during the presentation. So, speak now or forever hold your peace.
So I did think about one more thing, which is sometimes patients and families just have questions. And so we're happy to do what we would call a hospice informational visit. And so this would be one of our hospice team members coming out to the house or talking to someone on the phone to just get a sense of, is now the time to make this transition to hospice care? So they may have questions, as we talked about insurance coverage. They may have questions about what does it really mean to be a hospice patient? And so I think our staff can really answer specific questions that patients and families have, again, either with an in-person visit in the home or by phone, again, as just a way to give people more information to decide if this is something that fits for them, either now or maybe in the future as things change with their illness.
Yeah, it never hurts to get the information sooner rather than later, even if it's not within the 6-month time frame or anything like that. It never hurts to just absorb as much information as you can about it, so that way when it's time, you're prepared and you know what options you have available to you. So.
I would just add that if anybody watching this wants sort of more of a day in the life of any of our hospice team, we were thinking about that before for a presentation, but I think there might be value in that. So whoever, if anybody's watching this and thinking about maybe we're doing some more personal stories or having our team come on and just talk about what they do, we'd be happy to set that up.
Absolutely. Jess Allen or Jen, anything else to add? I will take that as a no. Jess Allen?
I would just add this. Yeah. Hi, Anthony. This has been a great team to work on. One more piece that I want to add about our hospice team is each member of our team specializes in hospice. Our nurses, our social workers, chaplains, even our LNAs are focused solely on our hospice program, providing great care to our patients.
Excellent. All right. And if there's nothing else, I want to thank the 4 of you for joining us on Let's Talk this evening or this afternoon. And again, if there are any questions about hospice services or anything like that, in addition to finding out more about how you could volunteer to be a part of the hospice team, just go to vnhcare.org and we'll be able to provide that information to you, provide any informational information that you might need, just anything you need. We're here to help you out. So again, we've lost Jess Allen, but thank you all for watching this, whether it was live or the recording later. And again, thank you all so much for doing this presentation.
Thank you, Anthony.
Thank you, Anthony.